Hello coders! Today we are doing radiology part 1. So we're mainly going to be talking about X-rays, CAT scans, CTAs, magnetic resonance imaging, MRAs, and then in radiology part 2, that's where we're going to talk about ultrasound, excuse me, radiation oncology, and nuclear medicine. When it comes to radiology, there are really two easiest ways and the third kind of sort of easy way. First things first, if you know the procedure name, like a duodenography, then you can look up that full term. But most of the time, we're given the type of test and then the anatomic site. So for types of tests, we can look up things like X-ray, CT scan, but here's where we have to be careful. Instead of calling it a CTA, in the index, it spells out computed tomographic angiography. The difference between a CT and a CTA, a CT is looking at body structures, it's looking at the organs, it's looking at the muscles, it's looking at bones. Versus a CTA is looking at the vessels that are going in and out of those organs. And so that's the big difference. It's that computed tomography is looking at basically organ systems and the bones and the connective tissue and the muscles, but the angiography is really looking at the vessels of that part of the body. Same thing goes for magnetic resonance angiography versus magnetic resonance imaging. Magnetic resonance imaging, again, is looking at body parts. Magnetic resonance angiography is looking at the vessels of those body parts, okay? Again, in radiology part 2, we're going to pick up with ultrasound. Again, we're going to talk about nuclear medicine. We're going to talk about all the differences between radiation oncology, radiation physics, radiation therapy. But you can also look up things under the general term radiology. And again, in radiology part 2, we also talk about mammography as well. So the first thing I want to do is I want to talk about what do these tests mean and what do they look like. So in a lot of my other chats, we have talked about fluoroscopy. So this right here is what I mean by fluoroscopy. This is one version of it. So again, this is a machine that runs on a track above an actual surgical bed. Okay, and what they can do is they can move this piece of X-ray equipment all over the patient so that they can see what's going on. And again, it's allowing the physician to view the inside of the body using X-ray equipment. And again, remember, this sends a live feed from above the patient to a computer screen in the room. And in this case, here's the computer screen. Again, we have to remember in this day and age, computer screens and TVs are interchangeable nowadays. So if you were to walk into an operating room and there is an HD TV there, then that can be used as much as a monitor as what we consider a classic computer monitor. Either way, it has all the connections that can connect to a computer. If you want to learn more about this, I found some great information at FDA.gov, which is where I got this picture. And you can go under the radiation emitting products, and it will give you information about all the different tests we're going to talk about. So most of us are pretty clear about what fluoroscopy is. It's using X-ray. X-ray itself, this is part of their definition from FDA.gov. An X-ray beam is passed through the body where a portion of the X-rays are either absorbed or scattered by internal structures, and the remaining X-ray pattern is transmitted to a detector like a film or a computer screen for recording or further processing by a computer. So when they mean that the beam is either absorbed or scattered, most of our internal organs are going to absorb the X-ray beams, which is why here you don't see the outline of the lung, you see the outline of the ribs, because the scattered goes all around so we can see the bone structure. Here are the clavicles, sternum's right here, which is why it's bright white, and then the ribs themselves. Again, also on FDA.gov, which is where I got this picture. So again, most of us are clear because we've had X-rays, we've heard about X-rays. X-rays were really the first radiology that came out in the 1800s, the late 1800s. And since then, we've been able to update it. We went from X-ray to fluoroscopy, and eventually we did stuff like CT scans or CAT scans. So CT scan stands for computed tomography. It's also known as CAT scanning, computerized axial tomography. Again, when we're talking a little bit about math in one of my last sessions. And again, this is where axial, we are making slices. So it tells us this provides a different form of imaging known as cross-sectional imaging. The origin of the word tomography is from the Greek word tomos, meaning slice or section, and graph, meaning drawing. CT imaging system provides cross-sectional images or slices of anatomy, like the slices of a loaf of bread. And again, so basically we're slicing across the body. So right here, this is a view of the abdomen. How do I know that? Well, here's the spine. There's a kidney on either side. Over here, we start seeing the stomach. We see some of the small intestines, all of this stuff. But again, we can slice any part of the body. We can look into the brain. We can look into the foot. We can look into any part of the body. And what we do is we create these slices through imaging equipment. And then what we do is sometimes we can actually use 3D imaging to recreate it so that we can see if an organ is too large or too small. If there's a tumor, if there is a tumor, how big is a tumor? Where has it extended to? And so there's a lot of great reasons why we might want to do a cross-sectional slice of the body versus just taking an X-ray. Again, as I said, CTA, again, is still taking slices of the body, but in this case, we're specifically looking at the vessels. So you can see here, you can kind of see some of the vessels, like these are the ureters from the kidney, but that's not the same thing as the renal artery or vein. Okay, so keep that in mind. Now, MRI. Again, this is from FDA.gov. Magnetic resonance imaging is medical imaging procedure for making images of internal structures of the body. MRI scanners use strong magnetic fields and radio waves to make signals. The signal of an MR image comes mainly from the protons in fat and water molecules in the body. During an MRI exam, an electrical current is passed through coiled wires to create a temporary magnetic field in the patient's body. Radio waves are sent from and received by a transmitter receiver in the machine, and these signals are used to make digital images of the scanned area. So down here, basically the patient gets placed inside of the MRI machine. Now this is considered a closed MRI because you go completely inside of it. They have open MRIs where one side is completely open. And you can see here, what this does, it creates this magnetic field around the body. When we send these radio waves into the body, what happens is that the magnetic waves that are dealing with the fat and proteins in our body send back images of our internal organs and our bone structures. And again, we can also look at our vessels. We can do a magnetic resonance angiography as well. And so, you know, for the longest time, CT and MRI were kind of fighting with each other. Couple major differences between them otherwise than the machine itself. CT scans take less time and they're a little bit cheaper, but they also don't get nearly as great as an image as an MRI does. MRIs can take anywhere from 2 to 5 times longer than a CT scan, but you do get a better image. And what you'll notice is in the field, some insurances will pay one, but not the other, or you have to get one before you can get the other done. And that's very classic because these technologies are pretty much neck and neck now. And it really depends on what we're looking for and what the doctor thinks they are going to see best from one of these tests. So let's start talking about our green guideline pages. So this is page 447 in your radiation guidelines. Now, this is very important. We are going to see tests that are without contrast, tests that are with contrast, and tests that are without contrast followed by with contrast. So again, it depends on what we're looking at and why we're looking at it. If we're looking at the vessels, most likely we're going to use contrast. Why? Because the contrast that we inject into the patient's vessels are going to show us if there's any occlusion or stenosis or any arteriovenous malformation. However, contrast can be used for so many different purposes to show so many different parts of the body in different lights. Here is the big thing. The phrase with contrast used in codes for procedures performed using contrast for imaging enhancement represents material administered intravascularly, intraarticularly, and intrathecally. Okay? So, intravascularly into a vessel, usually a vein, intraarticularly in a joint of some sort, a knee, a shoulder, a hip, or intrathecally. Intrathecally, keep in mind we're talking about going up towards the brainstem and the spinal cord, okay? But you'll notice these are all injections. For it to be contrast, it must be injected. And how do we know that? I will show you. At the top of the next column, says right here, oral and rectal contrast administration alone does not qualify as a study with contrast. So if the patient drinks a contrast or contrast gets inserted rectally, that is not a with contrast test. Contrast has to be injected. Again, whether we're going into a joint, whether we're going to a vessel, whether we're going to the spinal cord, doesn't matter. It must be injected to count as contrast. So for instance, if someone is doing a CAT scan of the abdomen and the patient is drinking contrast, that's going to be a CT of the abdomen without contrast. Here's the thing though. When you inject contrast into a patient, it can take anywhere from an hour to 5 to 8 hours for that contrast to come out of the patient's body. So even though what's classic for providers to write is with and without contrast, so CT abdomen, with and without contrast, okay? We never do with and then without contrast. We always do without followed by with. So the patient will come in, they'll get scanned through the machine, they get pulled out, they get the contrast injected, they wait 15, 20 minutes, they scan the patient back in. Okay, so that's always how it works. So our choices will be without contrast only, with contrast only, or without contrast followed by contrast in the same session. One more thing to keep in mind, written reports. Our radiologists are required to write reports to get paid. So a written report, handwritten or electronic, signed by the interpreting individual, should be considered an integral part of the radiologic procedure or interpretation. So this is just like if you go to a primary care physician for an office visit. They are required to write up the office visit for billing purposes. If you get an X-ray done, whether it's a primary care physician, an orthopedist, or a radiologist, they have to read and write a report to get paid for the service, okay? And these images can either be on film or they can be digital, okay, in an electronic manner. So it doesn't matter. Most of the time, these are going to be on some form of digital or electronic means. So when we flip to page 448, the first thing we're going to see is it says Diagnostic Radiology, Diagnostic Imaging, Head and Neck. Now, this is what I was talking about earlier. So you could look up terms like myelography or cysternography in the back of the book. But when you see the word radiologic examination, X-ray, okay? A radiologic examination is always an X-ray. So in this case, if the doctor told us that we are doing an X-ray of the eye for detection of foreign body, we would look up in the back of the book, X-ray eye detection foreign body, and it would bring us to 70030. Now again, in general, X-rays do not use contrast in general. But there are some tests that we can use contrast that use X-ray equipment. So keep that in mind. So most of these are going to say things like radiologic examination. But I want to show you here. One of the things with X-rays is how many views. So most of the textbooks that go over radiology talk about the different positions that patients can be in and the different views that we can get. In the last couple of years, radiology has gotten updated to the point where we really don't need to worry about what position. We need to know how many views for X-ray. So basically, how many separate X-ray pictures are we taking? So if we're doing a radiologic examination of the mandible, okay, so that's the jawbone, partial less than 4 views. So code 70100 would be for 1, 2, or 3 radiological views of the mandible. If we're doing 4, 5, 6, 8, 10, 70110, minimum of 4 views. So again, even down here for the mastoids, less than 3 views, more than 3 views, okay? So we need to basically know how many views are we taking? How many separate static X-ray images are we taking based upon what was ordered? So one of the things I want to make it very clear, sometimes technicians do help code for this, but it is up to the biller and coder to make sure that they in fact pick the right code. And the biggest part of this is double checking any type of modifier. Because remember, modifier TC in 26 is for when we have radiologic equipment that is not owned by the facility. Okay, some facilities rent their equipment, some facilities own their equipment. If the facility owns their equipment, there's no modifier because the doctor that owns the equipment is also the one taking the X-ray and reading and writing the report. However, in other facilities, they may separate out technician duties versus radiology duties for the written reports. In that case, you would want to clarify with the facility how they bill that out for specific insurances. So again, that's a question if you're thinking about going into radiology or going into a facility where you'll be doing some radiology coding, is asking them about their structure for modifiers. Do they use them? Do they not? And again, this is going to go through every part of the body. So for the head and neck, we're going to go through all of our different X-rays. Then as we keep going through, we're going to start seeing the commuted tomography. 70450 is commuted tomography, head of brain. This is without contrast. 70460 is with contrast. 70470 without contrast material followed by contrast material and further sections. So this is the way it'll always go. For our commuted tomography and our MRIs, it's always going to have a standalone code without contrast, first indented code with contrast, second indented code without contrast, followed by contrast. So that's something we always want to keep in mind, and be careful when you code these. So we want to make sure we've gotten to the right area. If we continue on to page 449, this is where you start seeing the magnetic resonance imaging. And again, so this is an MRI of the orbit, face, and or neck. Again, we'll still see without contrast materials, with contrast materials, and then without contrast materials, followed by contrast materials. You'll also see if there's an angiography of the same part of the body, they will give us a notation. So if we got to the wrong place, we can go, oh, we're close. We only have to go a little bit further to find these. Speaking about finding them, again, we have, again, along with our magnetic resonance imaging and angiographies, I want to show you this. So this is still on page 449. So they say functional MRIs involve identification and mapping stimulation of brain function. When neurofunctional tests are administered by a technologist or other non-physician or non-psychologist, use 70554. When neurofunctional tests are entirely administered by a physician or psychologist, use 70555. So basically, they're using MRI technology, but what they're doing here is usually when the patient looks up to the top of the machine, there's going to be a series of pictures, basically, like a little screen, and they're going to try to evoke different emotions from the patient. So one of the first sets of fMRIs that were ever done before they were available to the general medical community was actually done, believe it or not, on male serial killers, people who had killed more than 3 different people. And what they were looking for is they got some test subjects that were considered normal brains and never had any type of interactions with the police. And then they did a whole bunch of these men who were, most of them, in jail for life. And they scanned their brains. And what they found is things like the pleasure center of the brain of these serial killers was in a completely different area, and they got excited by very different things. You know, things like violence would get them excited, versus for a normal person, it might be seeing a beautiful picture of a sailboat at sunset, on a beautiful island. And this is one of the first things where they started mapping the brain to really get a better understanding of where our emotions come from, and to start looking into the fact that certain people that have done some really heinous crimes do have a slightly different brain structure. And so that's where this came out of, which is very, very interesting. But now they do this for a variety of purposes, especially if someone's had like a stroke, traumatic brain injury, things like that. And again, these can match with the neurofunctional testing from medicine. So keep that in mind, all right? So as we keep going through radiology, this comes a couple pages later, so we will find this on page 457. Page 457 has this lovely little table. So basically what they did many years ago is they made a series of codes for when we do the abdomen and pelvis. The big thing here is, what are we doing to what section? And again, we always have to know without contrast, with contrast, or without contrast, then with. So basically, I use the 2-finger method. So what I would do is I would say, okay, so the doctor just told me we did a CT of the abdomen with contrast. So that's up here, okay? And then they said they did the CT of the pelvis with contrast. That's down here. So what I would do is I would move my 2 fingers together, and 74177 is the code they have in common. And that's because, again, we have to remember that although the abdominal and the pelvic cavity are considered separate cavities, there's actually no distinct separation, like the diaphragm, which separates out the thoracic and abdominal cavity. We also have to remember that certain organ systems run from one into the other, like the urinary system. It starts up in the retroperitoneal area, ends up in the abdominal cavity, ends up in the pelvic cavity. So again, we see a lot of these tests being paired together. So when they are paired together, we only use one code to describe the testing. All right. So I want to show you guys this because this is one that if you haven't seen in like a medical terminology or anatomy and physiology book, a lot of people forget about it. So I'm looking at like 74240 and 74241. It has without KUB or with KUB. KUB stands for kidneys, ureters, bladder. So again, this is one of those things that a lot of people forget. Now, the reason why they forget is because when we look at the code descriptor, it says radiologic examination, gastrointestinal tract, upper, with or without delayed images with KUB. So again, it's because we're looking at the gastrointestinal tract, and guess what sits basically behind the gastrointestinal tract is the kidneys. And then again, as I was saying, The biggest thing about the kidneys, always remember this. The kidneys are the only organs that sit outside of an actual cavity. The kidneys sit in the retroperitoneal area. They sit behind the peritoneum, okay, but they are nestled by the floating ribs on our back, okay? But remember, the ureters then go into the abdominal cavity and continue into the pelvic cavity where they meet up with the bladder, okay? So keep that in mind. I just want to always show people that to remind them. And again, all parts of the body, all organ systems, all of this. Now, as we get through all of the organ systems, we get to the heart, which is separate. And our guidelines tell us why the heart has its own set of guidelines, its own set of codes. So it tells us, cardiac magnetic imaging differs from traditional magnetic resonance imaging in its ability to provide a physiologic evaluation of cardiac function. Traditional MRI relies on static images to obtain clinical diagnosis based upon anatomic information. Improvement in spatial and temporal resolution has expanded the application from an anatomic test, just looking at the organs, to include physiologic evaluation and cardiac function. So again, remember, physiology, how does it function? So we're looking at things like how do the valves function, how do the chambers of the heart function as a whole as well. And again, because technology has gotten better, now we're able to perform these tests easier. So it goes on to tell us what else it does. So we can do things like flow and velocity assessment for valves and intracardiac shunts is performed in addition to a function and morphologic evaluation. Use 75559 with 75565 to report flow with pharmacologic wall motion stress evaluation without contrast, and use 75563 with 75565 to report flow with pharmacologic perfusion stress with contrast. So these can be done with stress. Again, usually pharmacologic stress, meaning, again, we inject the patient with a drug that's going to speed up their heart rate, and then we inject them with another drug that's going to get their heart rate back down to normal, and we're going to test them to see what the differences are. Now, they tell us that cardiac MRI for velocity flow mapping can be reported in conjunction with 75557, 59, 61, or 63, because it is an add-on code. Now, listed procedures may be performed independently or in the course of overall medical care. If the individual providing these services is also responsible for a diagnostic workup and/or follow-up care of the patient, also see appropriate sections. Only one procedure in the series of 75557 to 75563 is appropriately reported per session. Only one add-on code for flow velocity can be reported per session. So again, per session. So that means if the patient has a cardiac MRI at 9 o'clock in the morning, another one at 4 o'clock in the afternoon, those are different sessions. Keep that in mind. Now, cardiac MRI studies may be performed at rest and/or during pharmacologic stress. Therefore, the appropriate stress testing codes from the 93015 to 93018 series should be reported in addition to 75559 or 75563. Okay, we also have CT and CTA. So they tell us cardiac computed tomography and coronary computed tomographic angiography include axial source images of the pre-contrast, arterial phase sequence, and venous phase sequence if performed, as well as the two-dimensional and three-dimensional reformatted images resulting from the study, including sign review. One of the big differences between what used to be a cardiac MRI and what is now a cardiac MRI is they are not only taking images of the heart, of the valves, but they are then putting it together in a 3D image to see how the heart actually functions after the fact. Now, contrast enhanced cardiac CT and coronary CTA codes 75571 to 75574 include any quantitative assessment when performed as part of the same encounter. Report only one computed tomography heart service per encounter. So it's only one per encounter. Again, they can have different ones done on the same day as long as they're at separate sessions. And again, with or without contrast material, with or without stress imaging. We need this information from the provider so that we know exactly what we're coding for. Now, the next section is one that we've seen quite a few times already. So we have seen this in cardiac surgery. We have seen this in medicine, and now we're seeing it also in radiology. Now, the guidelines are basically the same no matter what section. So we're going to talk about again, just in case you haven't gotten to those other sections and in your coding life. So the first thing to keep in mind is these procedures can only be done in very specific circumstances and only in those specific circumstances. Otherwise, we will not get paid. So what you'll notice is I've written when we can code and when we can't code. So let's go through these. Selective vascular catheterization should be coded to include introduction in all lesser order selective catheterization used in the approach. Example, the description for a selective right middle cerebral artery catheterization includes introduction and placement catheterizations of the right common and internal carotid arteries. So remember, the difference between selective and non-selective catheterizations is whether or not we are moving the catheter from one vessel into the branch of another. So, for instance, if you look at page 461 in your code book, you're going to see the aortography. Okay, so we stick the catheter directly into the aorta. That's non-selective. But if, let's say, we stuck it in the aorta and then went over to the renal arteries, now it's selective. We've gone into a branch, okay? Now, additional second and or third order arterial catheterizations within the same family of arteries supplied by a first order artery should be expressed by 36218 or 36248. And again, because this matches back with cardiac surgery. Additional first order or higher catheterization of vascular families supplied by a first order vessel different from a previously selected and coded family should be coded separately using the conventions described above. Now, just as a reminder, we do in fact have an appendix that will help us with this. So let's go to Appendix L. Appendix L starts on page 798, and this is our vascular family. This is how you can tell whether it's going to be a first order, a second order, a third order, or beyond the third order. You need to know where they're starting, where are they putting that catheter into, and then where are they going to. And as you figure out where they're going, that's when all these branches show up. And that's when you know how far you have to go to make sure you're coding under the right section. Now they go on to tell us the lower extremity endovascular revascularization code describing services performed for occlusive diseases include catheterization in the work described by the code. So again, when we did that in the cardiac surgery portion, again, what is included in your codes? Catheterization codes are not additionally reported for diagnostic lower extremity angiography when performed through the same access site as therapy performed in the same session. So again, a lot of what this has to do is what's included in another procedure, but also, again, if we are already in a vessel, we're already doing a therapy, we can't code separately for an angiography because we haven't moved that catheter. So that's what they're telling us. However, catheterization for a diagnostic lower extremity angiogram may be reported separately if a different arterial puncture site is necessary. So again, in this case, they're telling us when we can and when we can't code for these. Now, the next part is what you'll probably have seen quite a few times. So let's go down to this is when we cannot code this first part. Diagnostic angiography code should not be used with interventional procedures for contrast injections, angiography, road mapping, and/or fluoroscopic guidance for the intervention, vessel measurements, and post-angioplasty, stent, arthrectomy, angiography, as this work is captured in the radiological supervision and interpretation codes. In those therapeutic codes that include radiological supervision interpretation, this work is captured in the therapeutic code. So the biggest thing here is there are a lot of cardiac surgery codes, cardiovascular surgery codes that include this because it's part of what they're already doing. But we can code it separately if the patient fits into one of these scenarios, okay? So diagnostic angiography performed at the time of an interventional procedure is separately reportable if no prior base catheter angiographic study is available and the full diagnostic study is performed and the decision to intervene is based on the diagnostic study, or a prior study is available but documented in the medical record either as A, the patient's condition with respect to the clinical indication has changed since the prior study, or there is inadequate visualization of the anatomy and/or pathology, or there's a clinical change during the procedure that requires new evaluation outside the target area of intervention. So basically, this is what you need to keep in mind. We can code these if they've never had one before, or if they have had the study done before, but something has changed, perhaps the film is just too old, or there's been a clinical change. So again, how does the provider describe the patient as we're going through these interventions? It goes on to tell us that diagnostic angiography performed at separate sessions from an interventional procedure is not separately reported. If diagnostic angiography is necessary, is performed at the same session as the interventional procedure and meets the above criteria, meaning it was separate or new, modifier 59 must be appended to the diagnostic radiological supervision and interpretation codes to denote the diagnostic work has been done following these guidelines. So again, 59 because it's separate and significantly different. So again, saying that maybe something has changed and that's why we're doing the angiography. Now again, diagnostic angiography performed at the time of an interventional procedure is not separately reportable if it is specifically included in the interventional code, which is where we have to be careful, okay? So that's the big thing. When can we and when can we not? When we flip the page, we get to the veins and lymphatics, and guess what? The notation I always make, I'll show you, is same as arteries. So, biggest thing here, when can we, when can't we? So, it tells us, again, diagnostic venography codes should not be used with interventional procedures for contrast injections, venography, road mapping, and/or fluoroscopic guidance for the intervention, vessel measurements, and post-angioplasty, stent venography, as this work is captured in the radiological supervision and interpretation codes. So again, the only difference between the wording from the arteries to here is instead of, using the arterial terms, we're using the venous terms. That's all the difference is. It goes on to tell us, this is when we can code, and it's almost exactly the same. Diagnostic venography performed at the time of an interventional procedure is separately reported if no prior catheter-based venography study is available and the full diagnostic study is performed and the decision to intervene is based on a diagnostic study, or, again, the other scenarios that we can use, a prior study is available but documented in the medical record as the patient's condition with respect to the clinical indication has changed since the prior study, or there is inadequate visualization of the anatomy and/or pathology, or there's a clinical change during the procedure that requires new evaluation outside the target area of intervention. So again, for both the arterial and the venous and lymphatic, We don't code when it's included in the code descriptor as long as it's within the same vessel. We can code when we've never done one of these before or something has changed, either prior to having the study done, while we're having the study done, or because a prior study is just not that great, maybe it's old. Okay, so again, same exact guidelines. And then it goes on to remind us that diagnostic venography performed at a separate setting from an interventional procedure is separately reported. And diagnostic venography performed at the time of an interventional procedure is not separately reported if it is specifically included in the interventional code descriptor, which for most of the interventional codes, it is included. So again, be careful. Remember, cardiology is in 3 parts. It's in surgery, it's in radiology, it's in medicine. Always make sure you've gone back to your guidelines to know what is included in those procedures. Now, let's talk a little bit about transcatheter procedures. As I've said in some of our other chats, we try to do as many procedures as we can with the smallest incisions possible. So we try to do a lot of percutaneous transcatheter procedures. Why? Because it's a small puncture into usually a vein, but it could be an artery. And they're relatively simple to do because, again, we're not slicing and dicing the patient. We're able to use the catheter to thread from one part of the body to another. So it tells us therapeutic transcatheter radiological supervision and interpretation includes the following services associated with that intervention. So this is what is included, okay? Contrast injections, angiography, venography, road mapping, and fluoroscopic guidance for the intervention, vessel measurement, and completion of the angiography or venography, except for those uses permitted by 75898. And 75898 says, angiography through existing catheter for follow-up study for transcatheter therapy, embolism, or infusion other than for thrombolysis. So, again, this is a follow-up after. So 75898 is the one little special code. Now, it goes on to tell us, unless specifically included in the code descriptor, diagnostic angiography and venography performed at the time of transcatheter therapeutic radiological and interpretation services is separately reportable. Example, no prior base study, etc. So again, we can only code it separately when it fits into one of those 4 categories. They've never had one or they've had one, but there's a change. Okay? And then goes on to tell us that codes 75956 and 75957 include all angiography of the thoracic aorta and its branches for diagnostic imaging prior to the deployment of the primary endovascular devices, including all routine components of modular devices, fluoroscopic guidance in the delivery of the endovascular components, and interprocedural arterial angiography to do things like confirm position, detect endoleak, and evaluate runoff. So again, the diagnostic imaging is all included because we want to make sure we're getting to the right place. Okay, so we want to keep that in mind. All right. The last set, which I did not take a picture of, starts on page 466, which are the other procedures. There's a lot of fluoroscopy here. And then, of course, ultrasound, which comes in the radiology part 2. Biggest thing here, if it's a simple test, X-ray, MRI, CT, CTA, look up the test and then the anatomic site. If they give you the full name for the test, like the the duodenography, you can look up that. But when it comes to anything dealing with catheters and vessels, be careful for what is and is not included in surgical and other interventional procedures. The other thing that you might want to do is you might want to look online and look at some more pictures, maybe watch a couple of videos about how some of this radiology is done so you have a better understanding for what the machines look like and what the images themselves look like. I know I showed you a few. There's a lot more out there and it's very, very interesting. All right, good luck, guys, and I'll see you in radiology part 2.